Hello, everyone. My name is Tahira Devji. I'm a first-year internal medicine resident at McMaster University, and I have here with me Dr. Ali Prebtani, Professor of Medicine in Internal Medicine and Endocrinology at McMaster University. On behalf of the Canadian Hypertension Specialist Society, CHES, we will be speaking about pheochromocytoma and paraganglioma today. We have no conflicts to disclose. So, Dr. Prebtani, what is pheochromocytoma and paraganglioma? How common are these diagnoses, and when should we be thinking about them?
Thank you, Tahira. So as you mentioned, pheochromocytoma and paraganglioma are also known as PCC and PGL, respectively. They are very rare neuroendocrine tumors which secrete catecholamines from chromaffin cells. And by definition, PCC refers to intraadrenal tumors, and PGL or paraganglioma refers to extraadrenal tumors in the sympathetic or the parasympathetic ganglia. In all causes of hypertension, they account for less than 0.1 to 0.5% of hypertension. And even if you investigate these patients, only 1 in 300 turn out to be a true bill pheochromocytoma or paraganglioma. However, if an adrenal incidentuloma is discovered, about 3% turn out to be pheochromocytomas. So when should you think about these conditions? There's a classic triad with hypertension associated with headache, palpitations, and sweating. The hypertension could be labile. They can have orthostasis due to significant volume contraction. Pallor is not uncommon. They can also present as panic attacks or with severe hypertension or hypertension refractory to more than 3 drugs. They can also be associated with syndromes with pheochromocytoma or paraganglioma, which I'll get into later on. And there can also be paradoxical blood pressure responses to anesthesia, surgery, or certain medications. And lastly, to also think about these conditions when someone has an unexplained cardiomyopathy. Rarely, they can also be asymptomatic. There are also some triggers or precipitants to someone who already has a pheochromocytoma or paraganglioma. Certain positions that can trigger catecholamine excess in these patients, abdominal pressure, labor and delivery, cough, especially in the setting of bladder paraganglioma, certain stressors, trauma, surgical stress or anesthesia, and certain medications, which I'll get into later. But many sympathomimetics can also trigger these spells in patients with an underlying tumor, metoclopramide, glucagon, and beta blockers due to unopposed alpha vasoconstriction. And lastly, certain tyramine-containing foods such as red wine and cheese can also trigger these spells in patients with underlying disease.
I've heard something about a rule of tens and familial syndromes. Can you go into that?
Sure, Tahira. Traditionally, there was something called the rule of tens, as you mentioned. And by definition, what this means is 10% are bilateral, about 10% are extraadrenal, 10% occur in children, 10% are recurrent, and probably less than 10% are malignant, especially if these patients are young, have a positive SD-HB mutation, if they're larger tumors, if they're extraadrenal, and have high free methoxytyramine levels in their biochemistry, which is a metabolite of catecholamines. In the past, it was thought that only 10% of these tumors had a genetic predisposition or were hereditary or familial syndromes, but there's probably more than 40%. There are several syndromes, which I'll briefly summarize. The first is multiple endocrine neoplasia, type 2, which are autosomal dominant, which are malignant less than 5% of the time, and they can be associated with pheochromocytoma, usually adrenal and bilateral. They can also have associated medullary thyroid carcinoma and primary hyperparathyroidism. Then there's MEN3, also known as MEN2B, again with pheochromocytoma, also associated with medullary thyroid carcinoma, and also some soft tissue manifestations such as mucosal neuromas and Marfanoid habitus. There's also von Hippel-Lindau disease, or VHL, which can also be associated with pheochromocytoma, which are adrenal and bilateral, which can also be associated with other tumors such as hemangioblastomas, renal cell carcinomas, cysts in the kidneys and the pancreas, and these tumors don't secrete epinephrine in this syndrome. Other syndromes include neurofibromatosis type 1 or NF1, also known as von Recklinghausen syndrome, which are also autosomal dominant. These have a low risk of cancer, mainly sporadic, and about 2% have pheochromocytoma. but is higher if they already have established hypertension. They can also have other manifestations such as cafe au lait spots, neophrobromas throughout the body, gliomas, and freckling. These patients have a higher risk of malignant nerve sheath tumors, breast cancer, and renal artery stenosis. There's also Carney's triad associated with gastric leiomyosarcoma and pulmonary chondroma. And lastly, and importantly, patients may also have succinate dehydrogenase mutations, SDH mutations, which are familial paraganglioma syndromes, autosomal dominant in nature, which usually don't secrete epinephrine. They can have associated renal cell carcinoma, gastrointestinal stromal tumors known as GIST, and many of them can also be silent, especially if they're in the head or neck.
So, what are some of the mimickers of pheochromocytoma and paraganglioma?
There are many, Tahira. Some of them include other causes of hypertension, especially labile causes of hypertension. Panic attacks are also in the differential diagnosis, but you never want to attribute a panic attack until you rule out organic disease because pheochromocytoma or paraganglioma can be fatal. There's a condition called pseudo-pheochromocytoma where they present clinically like a pheochromocytoma or a paraganglioma, but their biochemistry is totally negative, just like autonomic dysfunction from previous spinal cord injury or brain injury. Carcinoid syndrome is also in the differential diagnosis, thyrotoxicosis and other central nervous system lesions, drugs or drug withdrawal, in particular alcohol withdrawal or cocaine itself or cocaine withdrawal, and less commonly sleep apnea and sepsis. Often a good history, a physical examination, and appropriate biochemistry can rule in or rule out pheochromocytoma and help also establish these diagnoses.
And what if PCC and PGL go unrecognized and are untreated or poorly controlled?
Fortunately, this is still it's not a big issue these days, but it can still happen. But if uncontrolled or untreated, it can be associated with significant morbidity and mortality, in particular cardiomyopathy with congestive heart failure and end organ damage out of proportion to the hypertension, including retinopathy, nephropathy, and tachyarrhythmias. So it's really important to make sure these patients are well treated and diagnosed early on.
Missing a diagnosis of PCC and PGL could be catastrophic. Who should be screened and how should we go about doing that?
So patients with suggestive clinical features should be screened. Patients with an incidentally discovered adrenal or retroperitoneal mass, especially if it's lipid poor, more than 10 Hounsfield units on an unenhanced CT, should be screened. Importantly, if the Hounsfield unit is less than 10, it's very unlikely to be a pheochromocytoma or paraganglioma. And lastly, someone who carries a hereditary gene or a syndrome should also be screened. What are the important screening and diagnostic tests? We're using plasma metanephrines more and more because it's much easier to do, but it's important to do in the right way. They're supine for at least 20 minutes before the blood is drawn, and ideally speaking, they should have an indwelling catheter if possible to decrease the risk of false positives. Another important test we can also use is 24-hour urine catecholamines and fractionated metanephrines, but this is cumbersome, but can still be used in these patients to make it a screening test and a diagnostic test. And remember, the higher the levels, the more likely that it's diagnostic, especially if it's more than 3 times the upper limit of normal. The important thing to remember is to keep in mind that there's a lot of interfering substances and other dietary factors that may give false positives. Also, don't use the 24-hour urine VMAs or plasma catecholamines because these are not very sensitive or very specific. So the best tests, again, are plasma metanephrines or 24-hour urine catecholamines and fractionated metanephrines. And if there is a potential interfering substance, ideally speaking, it should be stopped 1 to 2 weeks in advance before testing.
What are some of these interfering substances or medications that can affect the accuracy of these screening and diagnostic tests?
So there are many, Tahira, and just think of anything that has any catecholamine in them. But one particular one I wanted to mention is acetaminophen, especially with plasma metanephrines, can have a significant impact. Labetalol or any other beta tricyclic antidepressants, monoamine oxidase inhibitors, sympathomimetics, levodopa carbidopa, often used for Parkinson's disease, and cocaine. Remember, just think about anything that has an effect on catecholamines or is a catecholamine metabolite or a catecholamine-like drug is going to have an impact either on the plasma studies or the urine studies. And they may have more of an effect on norepinephrine or vice versa. So it's hard to remember all this. So if you're not sure, think about all the drugs and ask about over-the-counter medications and about herbal stuff, and then go back to the table or a reference to make sure you can interpret the test accurately.
You mentioned lab-based tests for screening and diagnosis. Is there a role for imaging and diagnosis of PCC and PGL?
Absolutely. The first goal after the clinical and biochemical diagnosis is made is to anatomically localize the tumor. So the first test is a non-contrast CT adrenal protocol. However, if the Hounsfield unit is high, then you can do a washout study if it's going to change management, or a T2 weighted MRI of the abdomen. But more often than not, a non-contrast CT will be all that you need. If there is no abdominal tumor found or an adrenal tumor found, then you'll go on to do a whole body CT or MRI to look for extra adrenal or extra abdominal tumors or paragangliomas. Now, if the tumor is quite big, arbitrarily more than 10 centimeter in size, if it's bilateral or extra adrenal, or if you're thinking that this is malignant, then you'll go on to do functional or molecular or radionuclide imaging to see if you can detect tumor elsewhere, or there's metastases or widespread disease. And the first test will be a gallium-68 PET dotatate CT scan. Unless the tumor is poorly differentiated, this is quite a good test as a functional imaging test because many of these tumors have somatostatin receptors, and dotatate is a somatostatin analog. We used to do MIBG scanning in the past also to look for functional tumors, but this is not as sensitive, and there can be some false negatives with certain medications, in particular dihydropyridine calcium channel blockers. If the tumor is suspected to be poorly differentiated, then an 18 FDG PET CT may be useful. But more often than not, a gallium-68 PET dotatate CT scan will be the first imaging test if it's indicated to be done. Very, very important point is to always confirm clinically and biochemically first before doing any type of imaging, because you want to avoid the incidental finding, which can drive us all crazy and add to patient anxiety and cost, etc.
Can you help put this all together and go through your overall approach to investigating PCC and PGL?
Sure, Tahira. So the most important thing is that, as with anything in medicine, is to take a very good detailed history and physical examination, and if possible, to discontinue any potential interfering agents or foods, if possible, at least for 1 to 2 weeks' time, and do the appropriate biochemical testing, either plasma metanephrines or 24 urine fractionated metanephrines. If they're totally normal, you can probably be pretty sure this is not a pheochromocytoma or paraganglioma and look for alternative causes. If they're unequivocally increased, then you want to do localization study, first starting with an abdominal CT or an MRI. And if a tumor is found, voila, you've probably made the diagnosis. Then you may consider functional or nuclear imaging if you're thinking about an extraadrenal tumor, bilateral disease, or a large tumor more than 10 centimeter in size. If it's not that big and you don't meet any of these conditions, then a surgical consultation is appropriate at this time. If there is no localization with full body imaging or the tests are equivocal, then you may consider doing a whole body CT or an MRI. And if the tumor is found, again, you're going to follow the same process and consider surgical intervention. If there is no tumor found, then you're going to explore for an alternate diagnosis. Now, if the biochemistry is mildly elevated, like let's say less than 2 to 3 times the upper limit of normal, which is not uncommon, once again, go back to your history and physical, stop any interfering substances if possible, repeat the testing. If it's still equivocal and you're still thinking that the tumor possible, consider clonidine suppression testing for suppression of plasma norepinephrines.
Okay, so now we've made the diagnosis, we found a lesion. What are the principles of therapy?
So the first and foremost is fluid and sodium repletion. I let them have lots of sodium, lots of pizza, mozz clamato, etc., to make sure their volume replete, because these patients are often volume contracted. And general principles are using alpha-1 blockers, which I'll get into, beta blockers after adequate alpha blockade to avoid unopposed alpha vasoconstriction, and if necessary, to consider addition of dihydropyridine calcium channel blockers, ACE inhibitors, or angiotensin receptor blockers. Once you have adequate alpha and beta blockade with good volume repletion, then you want to try to attempt surgery or cure. And intraoperatively, it's important that you have on hand intravenous phentolamine, which is a intravenous alpha blocker, nitroprusside, which is a vasodilator, beta blockade to prevent tachyarrhythmias and heart rate control. And this will be done by anesthesia who has experience with pheochromocytoma or paraganglioma. And postoperatively, these patients often, if they're cured or the lesion is resected, they may become hypotensive, which is a good sign, and they may need lots of fluids and intermittent inotropes or vasopressors.
Is there any pre-workup needed? More specifically, presumably many of these patients will have high blood pressure. How important is it to control blood pressure preoperatively?
So, Tahira, this is where it's really important to personalize medicine. So at least every patient should get a baseline electrocardiogram. Should everyone have an echocardiogram? I would say not everyone, but someone who has suspected dilated cardiomyopathy, suggestion of cardiovascular abnormalities due to excess catecholamines, I would go on to do an echocardiogram, especially if they've had heart failure in the past. If there's a suspicion of a syndrome, you can do the associated investigations. For example, if they have MEN2 and you're worried about medullary thyroid carcinoma, then you would do the appropriate calcium studies, calcitonin, etc. So it depends on the type of syndrome, but I wouldn't screen everyone with the calcitonin unless you suspect they may have a medullary thyroid carcinoma or an associated syndrome. In terms of preoperative blood pressure control, this is really, really important to avoid a hypertensive crisis or a catastrophe intraoperatively or even without going for an operation. And this should be done at least 7 to 14 days before the operation to allow, and you want to really allow important volume repletion with lots of fluids. The goal is to aim for a blood pressure less than 130/80 and a systolic blood pressure greater than 110 standing so they don't become orthostatic. You're going to start off usually with selective alpha-1 blockers, such as doxazidine, which is the one I use, but you can also use prazosin and terazosin. In the past, we used to use phenoxybenzamine, which is a non-selective alpha blocker, but it's really hard to get this drug because it doesn't have a DIN number and it's very expensive. So now more and more, there's studies to show that probably the selective alpha-1 blockers, in particular doxazidine, is probably as good. And as long as they're well alpha blocked beforehand, they will do well. What about beta?
So beta blockade, this is to control reflex tachycardia and a tachyarrhythmia prophylactically in these patients. It's really important to start at least a few days after they've been adequately alpha blocked. Otherwise, you may have a hypertensive crisis because of unopposed alpha vasoconstriction. You want to aim for a heart rate of less than 80 supine and less than 100 upright. And if you suspect heart failure or dilated cardiomyopathy, you want to start slowly with a low dose and work your way up. If the blood pressure is still high, despite adequate alpha and beta blockade, you can consider usual antihypertensive, such as dihydropyridine calcium channel blockers, ACE inhibition, or ARBs. And you want to try to avoid diuretics as much as possible because they're already volume contracted, which can make things worse.
What about around the time of surgery? What are some of the other considerations to think about?
So in terms of perioperative preparation, it's really important that you connect with the surgeon and anesthetist, and we usually ensure that these patients get their oral blood pressure medications in the morning with some sip of water. And to avoid a perioperative hypertension or hypertensive crises, just in case, you should have onboard IV phentolamine, which is a short-acting non-selective alpha-1 blocker, and a vasodilator such as a nitroprusside IV. And to prevent tachyarrhythmias, they should have IV esmolol on board. So it's really important to work very closely with the anesthetist and the surgeon in order to make sure this occurs. We usually try to admit them the day before for saline or Ringer's lactate infusion to make sure they're more volume replete. And once again, to be redundant, to make sure that there's availability of these drugs by anesthesia, IV phentolamine, nitroprusside, and esmolol.
So everything has gone well. The patient has had the operation. What medical management, if any, do you recommend after surgery?
That's really important, Tahira. So in most cases, most of these patients can stop their blood pressure medications, hopefully that they may be cured. And post-op hypotension actually is a good thing where they may need temporary IV crystalloid, either saline or Ringer's, and temporary pressors or inotropes. At 5 years, about 3/4 are hypertension-free, and about half in 10 years. And the reason is, you may ask why, is because many of these patients also have primary underlying hypertension or essential hypertension, and it's not often the recurrence of the tumor. But you should still need to monitor and have surveillance for ongoing surveillance for this tumor. The other thing is that about a few weeks after, they should have repeat biochemistry ordered, either 24-hour urine or plasma metanephrin. And ongoing for at least 10 years, they should have biochemistry done at least yearly. And for high-risk patients, they should have lifelong surveillance for recurrence, especially if they're younger, the tumor was large, if they had a hereditary or a genetic syndrome or a paraganglioma, and if this condition was silent, because sometimes they can be silent, make sure you're doing appropriate imaging or scoping endoscopy, especially if they were, for example, silent bladder paragangliomas.
How do these patients do overall? What factors affect prognosis?
So fortunately for most pheochromocytomas or PCCs, adrenalectomy is curative, although they may occur in a small subset of patients. And metastatic disease, although it may occur, it's not very common with small pheochromocytomas. On the other hand, with paragangliomas, it depends on the size. The bigger it is, the more likely that they'll do worse or have recurrence or metastases. Depends on the site, depends on the surgeon, how complete was the resection, and also on the malignant potential of the tumor based on histology, pathology, if it was extraadrenal, the size, etc., and if they have a particular genetic mutation, in particular the SDH mutations, which carries a higher risk of recurrence and metastases.
You mentioned that some of these patients will develop metastatic disease. Amongst these patients who do, what treatment is available and what is the overall prognosis for these individuals?
Fortunately, most patients don't have metastatic disease, fortunately. And it's often hard to tell from pathology who are going to have malignancy. So it's just more or less following them along and looking at some features on the pathology that may help. The survival rates vary quite a bit. And with metastatic disease, it's roughly anywhere from a third to 60% survive or live at around 5 years. Of course, they do worse if they're older, they're males, the tumor is larger, if there was incomplete resection, and they had higher dopamine or higher methoxytyramine levels. The ones who do have metastatic disease often have the SDHB mutation, about a third of them, so they do worse. And one thing to remember with metastatic disease, either with the pheochromocytoma, which is metastatic, or paraganglioma, the treatment approach has to be multidisciplinary in nature. It's just not the endocrinologist. It includes the surgeon, the pathologist, sometimes the nuclear medicine doctor, the medical oncologist, the radiation oncologist, and the interventional radiologist. So this is really a group effort. It's not a one-person show. And as I said, fortunately, unresectable progressive malignant tumors are not as common as the ones that are not metastatic. And usually we just use the usual principles of medical therapy as for the usual paragangliomas and pheochromocytomas. But if they're unresectable, if they're progressive and malignant or metastatic, we may consider using advanced therapies in a multidisciplinary fashion, depending on the rapidity of the progression and the site of the disease. And this can include nuclear medicine therapies or radionuclide therapies, somatostatin analogs, because some of these tumors have somatostatin receptors, especially if they're slowly progressive. Anti-resorptives such as bisphosphonates or denosumab can be considered if they have bony mets to decrease skeletal-related events. Now, this data is extrapolated. Depending on the tumor and the progression, we can also consider tyrosine kinase inhibitors, such as sunitinib, and less commonly, if they're very rapidly progressive, chemotherapy can be considered in conjunction with the consultation of a medical oncologist. And for palliation reasons or symptomatic reasons, if there's local disease, which is causing symptoms, for example, the liver consideration or the bone consideration can be given to external beam therapy, radiofrequency ablation, or tumor embolization. There's also a medication called tyrosine, which inhibits tyrosine hydroxylase, which decreases catecholamine levels. This is for refractory cases or unresectable disease, where the usual medical treatment for blood pressure control is not working and other therapies are not helping or not indicated or contraindicated. This may be considered hard to get. You have to get special health Canada approval. And of course, long-term follow-up is very important. The most important message is for progressive, rapidly progressive tumors which are unresectable and malignant or metastatic. It's a multidisciplinary discussion. It's just not a one person or one doctor show.
You mentioned earlier that many of these patients, about 40%, will have genetic syndrome. So who should we be who should we be doing genetic testing for?
So definitely most people agree, or most experts agree, that all paragangliomas, which are extraadrenal chromatin secreting tumors, should get genetic testing because they have a higher risk of hereditary syndromes. And as I mentioned earlier on, more and more people with this disease do have hereditary syndromes, more than 40%. Someone who's young, less than 50 years old, someone who has features of a genetic or familial syndrome should get tested genetically. Someone who has a family history, this condition with the pheochromocytoma or paraganglioma, should get tested. Someone who has multiple tumors, a proven malignant tumor or bilateral disease, should definitely get genetically tested. There is a school of thought suggesting that all patients with even pheochromocytoma or an adrenal tumor should get tested. Again, there's not 100% agreement on this, but I think the key message is that for people to take away is that we should be testing more from the genetic end than we were in the past, because more and more of these tumors are coming at a hereditary predisposition based on a familial or a genetic syndrome.
So what's the bottom line? What are the key pearls you would like to share with our audience today?
So I tried to outline, hopefully in a practical manner, many of the pearls and the messages throughout the discussion that we had today, but I'll summarize this at a very high level. So pheochromocytomas and paragangliomas, fortunately, are very rare, but they are life-threatening if not diagnosed or screened for in the appropriate setting. Think of familial syndromes that I've already mentioned, especially if they have features of familial syndromes. Look at the skin, look at the soft tissues, look at other organs in the imaging, especially the kidneys for cysts and other tumors, head and neck, etc. The best screening and diagnostic tests are the plasma metanephrines or the 24-hour urine fractionated metanephrines and catecholamines, keeping in mind that you're aware of certain substances that can give false positives, and the position is important. And if possible, try this interfering substance at least 1 to 2 weeks in advance to avoid false positives. And if they're mildly elevated, especially then, stop them and repeat the testing. Another cardinal important feature is to first confirm biochemically, then image to avoid finding incidentalomas. The best first anatomical image to localize the tumor is a CT scan, but sometimes an MRI may help, but make sure you do an adrenal protocol. And in large tumors that are bilateral, extraadrenal, or large, or you think they're potentially malignant, think of doing functional or nuclear testing. And the first test would be a gallium-68 PET dotatate CT. In the past, we were doing MIBG scanning, but this is not really favored as much anymore because it's not as sensitive. And rarely you may need an FDG PET, especially if the tumor is suspected to be poorly differentiated. Principles of therapy include good fluid repletion, but specifically you want good blood pressure control and heart rate and tachyarrhythmia control. And you will start off with adequate alpha-1 blockade with drugs such as doxazosin. And thereafter, in a few days, you're going to go for a beta blockade, both preoperatively and perioperatively. And you want to give it at least 1 to 2 weeks where you prepare them quite well so there's no hypertensive crises intraoperatively. Once you've done this and there's a lesion or lesions, surgery is the mainstay for potential cure or even reducing or debulking. Genetic testing probably for most. And like I said, the jury is out if everyone should get it with a pheochromocytoma, but I would say we should be screening more with genetic testing with either a pheo or a paraganglioma in these patients. Clinical and biochemical follow-up is very important for almost everyone for at least 10 years, and lifetime probably for those at higher risk for recurrence, especially if they're younger, if it was a large tumor, and if they have certain hereditary syndromes. And yeah, that's basically the summary of these rare but fascinating.
Thank you very much, Dr. Prebtani, for your insights into these rare but very important conditions. For our audience, if you would like to learn more, please check out the McMaster Textbook of Internal Medicine. You can find this information in the chapter on pheochromocytoma and paraganglioma. Thank you.
Thank you so much for allowing me to do this, Tahira.